We'll begin again. So let's start with the final round of presentations. And we'll start with cholera vaccine. And I'll ask Dr. Sanchez, are you ready to introduce your section?
So I will be introducing the cholera vaccine session. I'm the chair of the cholera vaccine work group. Next slide. I want to thank, first of all, I want to thank the CDC lead, Jen Collins, who's done an amazing job of getting the work group all together. Other members of the group, ACIP member Matt Daly, there's ex officio members, ACIP liaisons, and technical advisors, as well as CDC contributors. And just want to thank them all because it's been a team effort, and certainly led by Jen Collins in a wonderful fashion. So the background and purpose of the work group: in June 2016, ACIP recommended the cholera vaccine CVD103 HGR, or Vaxchora, for adult travelers 18 to 64 years old from the United States to an area of active cholera transmission. In March of 2020, Emergent Biosolutions filed a biologics license application supplement with FDA to expand the age range for Vaxchora to children and adolescents 2 to 17 years of age. In October of 2020, the ACIP cholera vaccine work group was formed, and this past December, FDA approved Vaxchora BLA supplement, and so that's where we're at right now. So the policy topic under consideration by our work group is, should ACIP cholera vaccine recommendations be expanded to include children and adolescents 2 to 17 years old? So today's agenda, there will be a background on cholera and cholera vaccine that will be presented by Jen Collins. James McCarty from Stanford University and Emergent Biosolutions will speak on the immunogenicity and safety of Vaxchora in children. And also, and then finally, we'll conclude with the work group plans by Jen Collins again. Thank you.
Okay, we'll move on to the next presenter, please. Dr. Collins for Introduction to Cholera and Cholera Vaccines.
Good afternoon. Cholera is a toxin-mediated, acute, watery diarrheal illness caused by toxigenic bacteria Vibrio cholerae 01 or 0139, curved, motile, gram-negative rods. Cholera can be severe and rapidly fatal without proper treatment. It is endemic in more than 50 countries and could cause large epidemics. We will begin with microbiology and pathogenesis. Vibrio cholerae is a diverse bacterial species with pathogenic and non-pathogenic variants. More than 200 serogroups have been identified based on the O antigen. Serogroup 01 has 2 major biotypes, Altor and classical, and 2 serotypes, Inaba and Ogawa. Toxigenic Vibrio cholerae 01 and 0139 cause cholera and are the only 2 serogroups associated with large epidemics. Non-toxigenic 01 and 0139 and other pathogenic serogroups, which may be toxigenic, can cause isolated, usually mild gastroenteritis. Cholera epidemics are associated with unsafe water and inadequate sanitation. Vibrio cholerae has an aquatic reservoir, and human infection occurs via ingestion of contaminated water or food. Direct fecal-oral transmission can occur, but secondary cases are rare if sanitation is adequate. The incubation period ranges from hours to 5 days. Cholera is a toxin-mediated disease. After passing through the stomach, Vibrio cholerae have an unusual ability to survive and replicate in the small intestine. Vibrio cholerae are non-invasive, meaning the bacteria do not enter the intestinal epithelium. Rather, they produce cholera toxin, a protein composed of 1 toxic A subunit and 5 non-toxic B subunits. Cholera toxin subunit A enters the cytoplasm of intestinal epithelial cells and causes secretory diarrhea. Now to epidemiology. Cholera can cause explosive epidemics, and 7 pandemics have been reported since 1817. The current global cholera pandemic, caused by Vibrio cholerae L-Tor-01, began in 1961. Serogroup 0139 first emerged in 1992 in Asia. It was the first non-O1 serogroup cause of epidemic cholera, but now causes a small portion of cholera cases globally. In the current cholera pandemic, Asia and sub-Saharan Africa have the highest burden of cholera deaths. This map shows countries reporting cholera deaths and imported cholera cases to the World Health Organization during 2019, the most recent year of publicly available data. The blue shading represents deaths, with darker shading corresponding to more deaths. The black dots mark countries that have reported imported cholera cases. Cholera cases reported to WHO increased during 2017 through 2019. This graph depicts annual cholera cases with the blue bars and case fatality rate with the black line from 1989 through 2019. Since 2017, Yemen has accounted for at least 75% of annual reported cases. During 2019, 31 countries reported more than 923,000 cases and 1,900 deaths. However, global cholera estimates significantly underrepresent the true burden because many cases are not diagnosed or reported. Cholera in the United States and other high-income countries is primarily travel-associated because of safe water and modern sanitation. However, most international travelers from the United States do not get cholera because they do not visit areas with active cholera transmission, and they usually have good access to safe food and water. CDC's Travelers Health Branch monitors areas with active cholera transmission and updates this list monthly on the webpage shown to the right. As of this month, the 17 countries listed in the purple box were considered to have active cholera transmission. Like most infections, cholera is underreported in the United States. This figure shows the surveillance pyramid. And as with any illness, cholera cases that are confirmed and reported underrepresent the true burden of illness, as not everyone who becomes ill will seek care and have the infection diagnosed. With cholera in particular, some travelers may become ill while abroad, and others may experience mild illness that may not raise clinical suspicion for cholera. A descriptive study of national cholera surveillance data from 2001 through 2011 identified 111 cholera cases over this 11-year period. Patient age ranged from 1 through 85 years with a median of 44 years. 15 patients, or 14%, were 2 through 19 years old. 108 cases were diagnosed by stool culture, 107 of which were confirmed as Vibrio cholerae 01. No deaths were reported in this series. 90 cases, or 81%, were associated with international travel. This graph from the study depicts cholera cases by year and source from 2001 through 2011. Total cases and those associated with travel to Hispaniola, shown in purple, increased during 2010 and 2011. This coincided with the October 2010 onset of epidemic cholera in Haiti. Travel to other areas, shown in green, were also an important source of cholera cases during this time period. Domestically acquired cases along the Gulf Coast are shown in red. To pick up where this study left off, we used national cholera surveillance data from 2012 through 2018, the most recent year of finalized data. During the 7-year period, 64 patients with cholera were reported in the United States. Patient age ranged from 11 months through 87 years, with a median of 51 years. 5 patients, or 8%, were 2 through 17 years old. All cases were caused by Vibrio cholerae 01. 2 deaths occurred, both among adult patients. This table shows cholera cases in the United States from 2012 through 2018 by age group and whether they were travel associated, defined as international travel in the 7 days before illness began. Overall, 56 cases, or 88%, were travel associated. 5 cases, or 8%, occurred in children and adolescents 2 through 17 years old. And all of these pediatric cases were travel associated. This graph depicts all 64 U.S. cholera cases reported from 2012 through 2018 by year and source. Travel to Hispaniola is shown in purple, other international travel in green, and no travel in gray. Annual case counts have been 15 or fewer during this time period, and cases associated with travel to Hispaniola have been relatively less frequent since 2012. Now to clinical manifestations and diagnosis. Clinical manifestations of cholera infection can vary from asymptomatic infection, which makes up about 75% of cases, to cholera gravis, the most severe form of cholera, which makes up about 10% of cases. Risk factors for cholera gravis include high dose exposure, low gastric acidity, and blood group O. Cholera gravis is rapidly fatal if untreated. Clinical features include profuse, watery diarrhea, which can be upwards of 1 liter per hour in adults, characteristic rice water stools flecked with mucus and epithelial cells, vomiting, leg cramps, and findings of severe dehydration shown here. A definitive diagnosis of cholera is based on culture of stool or rectal swab specimens. Transport media and selective culture media are needed to culture Vibrio cholerae. Other stool-based diagnostic tests are shown here. Although some molecular panels used in clinical settings have a target for Vibrio cholerae, this is insufficient for diagnosis without serogroup information and confirmation of toxin production. Acute and convalescent serology is also sometimes used for diagnosis. Fluid management is the primary focus of cholera treatment. Patients with cholera gravis may require up to 350 milliliters per kilogram of fluids within the first 24 hours of illness. Moderately to severely ill patients should also receive antibiotic therapy. Now to immune response and vaccines. The immune response to cholera is serogroup specific. In other words, infection with serogroup O1 does not provide protection against O139 and vice versa. However, Vibrio cholerae LTOR O1 and O139 genomes are very similar and have identical cholera toxin genes. Immune responses targeting cholera toxin are common after cholera infection, but do not mediate long-term protection. Vibriocidal antibodies are the best known marker for protection against Vibrio cholerae infection. In a study in Bangladesh, every 2-fold increase in vibriocidal antibodies was associated with an approximately 40% reduction in risk of cholera. Lipopolysaccharide-specific memory B cells may play a role in mediating long-term protection. The cholera vaccine CVD-103HGR was derived from wild-type Vibrio cholerae O1. It is a single-dose, live, attenuated oral vaccine. It is a novice serotype and classic biotype and is cross-protective against other O1 serotypes and biotypes. To produce the vaccine, 94% of the gene encoding the enterotoxin subunit A was deleted, but expression of the non-toxic B subunit gene was left intact. The vaccine also contains a marker to differentiate it from wild-type Vibrio. The organisms are lyophilized or freeze-dried into a powder. It is reconstituted with a buffer solution which neutralizes stomach acid. This allows the attenuated organisms to survive passage to the small intestines, where the immune response occurs. CVD-103HGR was previously licensed as Oracol and Mutacol and produced by Berna. This was a 5 × 10⁸ colony-forming unit, or CFU dose. It was licensed in non-US countries in the 1990s, including Switzerland, Canada, and Australia. Production was discontinued in 2004 for business reasons. The current formulation of CVD-103HGR, or Vaxchora, is produced by emergent biosolutions and has an approved dose range of 4 × 10⁸ to 2 × 10⁹ CFU. The volume of the buffer is 100 milliliters for recipients at least 6 years old and 50 milliliters for recipients 2 through 5 years old. Vaxchora was licensed by FDA for use in adults 18 through 64 years old in June 2016 and for children 2 through 17 years old in December 2020. Current ACIP recommendations regarding lyophilized CVD-103-HGR, or Vaxchora, were published in 2017. Workgroup findings regarding efficacy and immunogenicity are shown here. The workgroup evaluated efficacy against severe diarrhea, defined as fecal output of at least 3 liters in 24 hours after oral toxigenic Vibrio cholerae 01 challenge. For the current formulation, the estimated efficacy was 90% at 10 days and 80% at 3 months. Similar efficacy was observed in studies of the previous formulation, Oracol or Mutacol. Of note, this was based on grade evidence type 1, or evidence from randomized control trials or overwhelming evidence from observational studies. The workgroup also evaluated vibricidal antibody responses and determined both formulations of the vaccine effectively induced these. Regarding adverse events, the workgroup commented that no vaccine-related serious adverse events were observed for either formulation. Vaxchora had a slightly higher prevalence of diarrhea, which was mostly mild, among vaccine versus placebo recipients. No other differences in adverse events between vaccinated and unvaccinated groups were found in the literature. This was based on grade evidence type 3, or evidence from observational studies or randomized control trials with notable limitations. Based on these findings, ACIP recommends CVD-103-HGR for adult travelers 18 through 64 years of age from the United States to an area of active cholera transmission. The current policy topic under consideration is should ACIP cholera vaccine recommendations be expanded to include children and adolescents 2 through 17 years old. Recently published pediatric studies of CVD-103-HGR are shown here. These studies and additional pediatric data will be presented by the manufacturer following my talk. Our workgroup will evaluate these data further during the grade and evidence to recommendation process. Several studies conducted in the 1980s and 1990s evaluated the safety and immunogenicity of prior formulations of CVD-103-HGR in children. These included randomized, double-blind, placebo-controlled trials conducted in Indonesia and Chile, and an observational study of Oracol administered in an Austrian travel clinic. In summary, these studies found that a 5 × 10⁸ CFU dose was much less immunogenic among children in Indonesia than had been observed in previous studies among adults in industrialized countries. Most of these studies therefore used a 5 × 10⁹ dose. The studies observed 51 to 81% vibricidal seroconversion. In addition, shedding of the vaccine strain was infrequent. The vaccine was generally well tolerated, although fever was more common among vaccine recipients than placebo recipients in one study. A single dose of vaccine did not confer long-term protection in one study, and the incidence of cholera was too low to evaluate short-term protection. Of note, the 5 × 10⁹ dose evaluated in these studies was higher than Vaxchora, which limits the applicability of the immunogenicity and effectiveness data. Nevertheless, these studies are informative because they demonstrate that a higher vaccine dose was safe and well tolerated among children. In summary, cholera is a toxin-mediated acute watery diarrheal illness that can be severe and rapidly fatal without proper treatment. It is endemic in more than 50 countries and can cause explosive epidemics. Most U.S. cases occur among travelers to cholera endemic areas. The immune response to cholera is serogroup specific, and serogroup 01 causes nearly all cases globally. The vaccine CVD-103-HGR is a single dose, live attenuated serogroup 01 oral vaccine The ACIP currently recommends for adult travelers 18 through 64 years old from the United States to an area of active cholera transmission. Thank you.
Thank you very much for that presentation, Dr. Collins. Are there any questions or comments from the voting members or the liaisons? I'm not seeing any, so thank you very much. We'll move on to the next presentation. Oh, sorry, David. Dr. Kimberlin, please go ahead. Forgive me.
David Kimberlin, AAP Red Book. I'm curious, with the approval of the supplemental BLA, has that been publicized? Has that been released in any way? Or if not, did it relate to the suspension of production of Vaxchora temporarily during the pandemic?
I believe I did receive a press release from FDA through our usual channels. I don't know if it was different. We might want to ask the company if it differed.
Okay, any other questions or comments? All right, great. So we'll go to the next presentation, which is by Dr. McCarty on Vaxchora safety and immunogenicity data.
All right, can you hear me?
Yes, we can.
Okay, great, thank you. Well, good day, my name is James McCarty, and I'd like to thank you for the opportunity to speak here today. By way of introduction, I'm a practicing pediatric infectious disease physician with the Stanford University School of Medicine, and I have been consulting with PaxVax, now Emergent Biosolutions, for over 4 years, focusing on cholera and chikungunya vaccine. Today, I will provide a brief overview of the single-dose live attenuated cholera vaccine, Vaxchora, also known as CVD-103-HTR, with a focus on pediatrics, including recently published as well as unpublished data. Next slide. In order to provide perspective, I will present some high-level background data and will then review the recently completed 006 pediatric study, including just published data from the youngest 2 to 5-year-old cohort. I review the acceptability, palatability, safety, and immunogenicity endpoints, and will review new long-term immunogenicity and partial dosing data. As mentioned, Vaxchora is a live attenuated single-dose oral cholera vaccine, which received FDA approval in 2016 for active immunization against disease caused by Vibrio cholerae 01 in adults 18 to 64 years of age traveling to cholera-affected areas. In 2019, the FDA approved a change in storage conditions from frozen to refrigerated storage, and in December of last year, expanded the age indication, making it 2 to 64 years of age. Next slide, please. Vaxchora has been evaluated in a phase 1 study and several randomized, double-blind, placebo-controlled phase 3 and 4 trials in over 4,000 subjects, 2 to 64 years of age, as summarized here. Objectives have included safety, immunogenicity, shedding, and clinical efficacy. In the phase 1 study, Vaxchora was shown to be well-tolerated and immunogenic in adult volunteers, with 88.9% demonstrating serum vibriocidal activity, that is SVA, seroconversion on day 14. I will provide more detail on the 003 cholera challenge study in the next slide to provide context for the newer pediatric data, but I do want to point out that in this study, SVA seroconversion, defined as a 4-fold or greater rise in titer above baseline, was demonstrated as early as 7 days post-vaccination. The 004 lot consistency study was a large trial performed in adults and provided further data on safety and immunogenicity. The 005 trial was an immunologic bridging study which documented the safety and immunogenicity of Vaxchora in older adults, 46 to 64 years of age. Next slide, please. The protective efficacy of Vaxchora was assessed in the 003 double-blind cholera challenge study. 197 healthy adults, 18 to 45 years of age, were randomized 1-to-1 to receive either a single dose of Vaxchora or placebo. Subsets of subjects in each group were then challenged with 10 to the 5th colonies of a wild-type L-tor Inaba strain at 10 and 90 days after vaccination. The primary endpoint was the prevention of moderate to severe diarrhea, and secondary endpoints included the number and volume of diarrheal stools, as well as serum virucidal antibody levels. Vaccine protective efficacy against moderate to severe diarrhea was 90.3% at day 11 and 79.5% at day 91. Vaccine-induced increase in virucidal antibody titers strongly correlated with protection, and 60 of the 62 vaccinees who seroconverted were protected after challenge. Next slide, please. This brings us to the 006 pediatric trial. 3 cohorts of children and adolescents, 2 to 5, 6 to 11, and 12 to 17 years of age were randomized 6-to-1 in a double-blind manner to receive Vaxchora or placebo. In the pediatric study, immunogenicity endpoints included SVA seroconversion rates 10 days after vaccination, which was day 11, cumulative seroconversion 28 days after vaccination, and geometric mean titers through day 730 in the oldest cohort, and through day 29 in the 2 younger cohorts. Safety was assessed through both solicited and unsolicited adverse events. Additional endpoints included acceptability, that is, the percentage of dose consumed, palatability. The primary endpoint was the proportion of participants achieving seroconversion at day 11. Next slide, please. There was an even distribution of subjects enrolled in the cohorts. 3 subjects, including 2 subjects in cohort 1 and 1 subject in cohort 2, were randomized to placebo but mistakenly dosed with Vaxchora. To be evaluable at day 11, subjects had to consume at least 80% of the study product, have serum specimens obtained on days 1 and 11, and have no protocol violations that might affect immunogenicity. The percentage of subjects evaluable at day 11 was lowest for the 2 to 5-year-old cohort, mostly for less than 80% of the dose being consumed, which occurred in 21% of Vaxchora recipients and 27% of placebo recipients. 72 adolescents participated in the long-term sub-study, and 62 completed through day 730. Next slide, please. High-level demographics for the pediatric study are noted here. There was an even distribution of male and female subjects. Other than age, the demographic and other baseline characteristics of the treatment groups and cohorts were similar. Next slide, please. Here are the dosing and palatability data. In the 12 to 17-year-old subjects noted on the right, 99.4% of Vaxchora recipients and 100% of placebo recipients consumed the complete dose. In the 6 to 11-year-old cohort, noted in the center columns, 91% of Vaxchora recipients and 96.2% of placebo recipients consumed the complete dose. And in the 2 to 5-year-old subjects, noted on the left, 79.5% of Vaxchora recipients and 73.1% of placebo recipients consumed the complete dose. The palatability assessments did not differ significantly between and placebo groups in each age cohort. Issues with palatability possibly contributed to the percentage of participants who did not consume a complete dose. For example, in the 6 to 11-year-old Vaxchora recipients with unacceptable dosing, 80% rated palatability as very bad. Subjects or their caregivers were given the option to add pure via stevia sweetener to the vaccine solution, and most chose to do so. We were unable to detect any improvement in palatability from the addition of sweetener. Slide, please. This graph compares overall safety in the pediatric and the 004 adult lot consistency trial. In the adult study, all solicited adverse events were considered to be related to study product, while in the pediatric study, each solicited adverse event was assessed by the principal investigator for relatedness to vaccine. There were no vaccine-related serious adverse events in any group. Next slide, please. Solicited adverse events were recorded daily by diary cards for 7 days after vaccination. There was a higher frequency of solicited reactogenicity in both the Vaxchora and placebo recipients in the 12 to 17-year-old cohort compared to the younger cohorts, consistent with a possible reporting bias in this more verbal age group. Abdominal pain and lack of appetite were reported more frequently by Vaxchora than placebo recipients in this age group, but the differences were not statistically significant. Most solicited adverse events were mild to moderate, and most resolved in 1 to 2 days. Next slide, please. Serious adverse events were reported in 1 of 468, that is 0.2% of Vaxchora recipients, and in 1 of 75, that is 1.3% of placebo recipients within 6 months of vaccination. None of these events were considered related to vaccination. Next slide, please. The study had 2 co-primary objectives: to demonstrate non-inferiority to adults from the 004 study in the rate of seroconversion, and to demonstrate a minimum seroconversion rate of 70%. The primary endpoint was this SVA seroconversion rate on day 11. SVA seroconversion rates were 99.4% in the 12 to 17-year-old group, 97.8% in the 6 to 11-year-old group, and 98.1% in the 2 to 5-year-old group, versus 93.5% in the adults age 18 to 45 in the 004 lot consistency study. And both primary objectives were met. Next slide. These are the SVA seroconversion rates represented in a bar graph. Non-inferiority criteria for seroconversion were met for each age cohort, and seroconversion rates were similar to the rate in adults. Next slide, please. These are the day 29 cumulative seroconversion rates for both Vaxchora and placebo recipients, also represented in a bar graph. Cumulative seroconversion at day 29 increased to 100% in the 12 to 17-year-old cohort and remained unchanged at day 29 in the 2 younger cohorts. Next slide. This graph shows the SVA geometric mean titers of vaccine and placebo recipients over time. In the 2 to 5-year-old and 6 to 11-year-old age groups, titers were only followed to day 29 to minimize the number of blood draws in the younger children. In the 12 to 17-year-old group, SVA geometric mean titers remained significantly higher than those in placebo recipients at all time points through day 181. Next slide, please. In a subset of the adolescent Vaxchora recipients, serum vibrio-sidal antibodies were followed for 2 years after immunization. Placebo recipients were only followed to day 181. As noted here, SVA seroconversion, defined as a 4-fold or greater rise in antibody levels over baseline, persisted in 64.5% of vaccine recipients at day 730. Geometric mean titers remained elevated at 133.8 at day 730, and geometric mean fold increase remained elevated at 4.1 at this time point. Next slide, please. Seroconversion rates were calculated in subjects who consumed less than 80% of the vaccine dose. These subjects were stratified into those who consumed 50 to less than 80% of the vaccine dose, and those who consumed any vaccine but less than 50% of the dose by each age cohort and in total. SVA seroconversion occurred in 100% of the subjects who consumed 50 to less than 80% of the vaccine dose, and in almost 70% of those who consumed less than 50% of the dose. These results were similar to those demonstrated in 1999 by Lagos et al. With CVD 103 HDR, who demonstrated similar seroconversion rates in infants and toddlers who consumed partial versus complete doses of vaccine. Next slide, please. In summary, virucidal antibody seroconversion rates in children and adolescents 2 to 17 years of age immunized with Vaxchora were non-inferior to seroconversion rates in adults. Vaxchora was well tolerated in the pediatric population with no vaccine-related serious adverse events. In an immunogenicity subset of Vaxchora recipients 12 to 17 years of age, serum virucidal antibody GMTs remained elevated 2 years post-vaccination, with 64.5% having levels fourfold or greater above baseline, and virucidal antibody seroconversion occurred in most children who received only partial doses of the vaccine. Next slide, please. In conclusion, the single-dose live attenuated cholera vaccine, Vaxchora, is safe, immunogenic, and likely effective in children and adolescents 2 to 17 years of age. Vaxchora may be used for the prevention of cholera in travelers 2 to 17 years of age visiting high-risk areas. Next slide, please. Thank you very much for your attention. I'm happy to answer any questions at this time or later.
Thank you very much, Dr. McCarty. Open for questions. Dr. Paling, please.
Thank you for this presentation on a very interesting topic. Would you please clarify the placebo that was used in these studies? Thank you.
The placebo is 0.9% saline.
Any other questions or comments? Ms. McNally.
Dr. Romero, my question might be better directed towards the work group or Dr. Sanchez, but because this is essentially a traveler vaccine for children, as the consumer representative, I'm just trying to understand how that would ultimately be given to children. Would it be in a pediatrician's office or elsewhere? Thank you.
Really, I can answer that. That has been discussed. This is Pablo. That has been discussed also in the work group, and it's likely that it would be administered in a travel clinic, but certainly could be administered anywhere. But it's likely that it's more of a travel vaccine.
Thank you.
Dr. Daly?
Yeah, thanks so much for that excellent presentation. And I had the opportunity to hear it in the work group too. And I just wonder if we could talk a little bit about the issues around the sweetener that was added. My understanding is that the sweetener doesn't have any effect on the vaccine in vitro, and that this data is pretty reassuring. But I just wondered if any sweetener is okay, or whether that can change gastric pH or gastric emptying in a way that would change vaccine efficacy. Thank you.
We do have stability data, stability studies that have been done with multiple brands of sweetener, including Purevia, Sweet Additions, Truvia, Splenda Natural, Sweet Leaf, also 4 grams of sucrose. Vaxchora is stable, being mixed with these for 30 minutes. There's one sweetener, Flavo RX, which is not compatible because it has propylene glycol, which can interfere with the organism. Yes, there is data on that.
Thank you.
So, Dr. Daly, just to add to that, the FDA does have data on this. We discussed this previously. So if you desire that, we can provide it.
Great, thanks.
Dr. Fry, please.
Thank you. Thank you for this interesting presentation. I just wanted to be clear on your definition for, or what definitions were used for seroconversion and what definition was used for seroprotection. Thank you.
Okay. seroconversion is defined as a fourfold or greater rise of serum virucidal antibody from baseline. Seroprotection refers really to the data provided by the challenge study, where those who seroconverted had a 90% protection at 10 days and 80% protection at 90 days following seroconversion, following challenge with cholera. And the fourfold or greater rise in serum virucidal activity after vaccination was very tightly linked with protection in that study.
Thank you. Dr. Fry? Yeah, no, do you have any other questions, Dr. Fry? Your hand's still good. Great. Anyone else? Thank you very much for that presentation, Dr. McCarty. So we'll move on now to Dr. Collins for work group plans.
So I'll briefly go over the next steps for the cholera vaccine work group. Today, we provided background information on cholera and CVD-103-HGR. The manufacturer presented immunogenicity and safety data on CVD-103-HGR among children and adolescents 2 through 17 years old. In June, we will present the grade and evidence to recommendation framework. The work group welcomes input from ACIP members as we begin this process. Assuming ACIP members are satisfied with the information presented in June, we will plan for a vote in October. Thank you.
Any questions or comments about that? Okay, very good. We'll move on to the next topic. Thank you very much. Next are orthopoxviruses vaccines. Dr. Bell, please, introduction and use of Vaccinia virus vaccine in persons at risk for occupational exposure to orthopoxviruses, the work group update.
Thank you very much, Dr. Romero. Very good, very good. Thank you so much, and thank you all for your continued attention at the tail end of this long several-day meeting. So I'm just going to introduce our session about the use of Vaccinia virus vaccine in persons at risk for occupational exposure to orthopoxviruses. Next, please. So the work group was initially formed with the objective of updating ACIP recommendations to include the use of JYNNEOS, a new vaccine, to prevent orthopoxviruses virus infection in persons at risk for occupational exposure. Next, please. This is a list of the members of our work group, including myself and Pablo Sanchez, and a number of ex officio members, invited consultants, and liaison representatives. Next. Here are the CDC contributors and subject matter experts from a wide variety of different groups at CDC. Next, please. So we first introduced the formation of the work group at the October 2019 ACIP meeting. And at the October 2020 meeting, we presented background information about orthopoxvirus vaccinations and ACAM2000, the currently available vaccine, and introduced considerations related to the use of JYNNEOS vaccine. Next, please. So since the last ACIP meeting, the work group has made a fair amount of progress in a number of areas. First, we identified a need to address the issue of booster vaccination with JYNNEOS. We discussed how to best consolidate previous ACIP orthopoxvirus recommendations into this update, and began discussing the evidence to recommendations framework as the ACIP leads continue to work on the systematic review. Next, please. So with that in mind, the work group's goals for today are to present background information and work group considerations in structuring recommendations for the use of JYNNEOS. In that regard, I think that the committee might want to just keep in mind a few key areas. One is a characterization of the populations at risk for occupational exposure to orthopoxviruses in the pre-event setting. And the second, as I mentioned, is the recommendations for booster doses in the context of very limited data, which the work group has spent quite a bit of time trying to sort out. Also, we will be describing the planned consolidation of various previous ACIP recommendations dating way back to 2003 into a single updated document. And we are looking forward to feedback and discussion about this proposed approach. Next, please. Our anticipated timeline is to update the ACIP about the work group discussions and new policy questions that we will be introducing to you today at the February meeting, which is now, to present the evidence tables and the evidence to recommendation frameworks for all of the policy questions which you'll be hearing about today at the June meeting. And looks like there are going to be potentially a number of votes at the October meeting. Our plan is to present the clinical guidance and the ACIP vote possibilities at the October 2021 meeting. Next, please. Today's agenda will include work group considerations by Dr. Brett Peterson and a description of the updated policy questions for the evidence to recommendation framework and the plan for the next steps from Dr. Ugam Rao. And I think that's it for me. Next, please. Yes, thank you very much.
Thank you, Dr. Bell. So let's go forward with Dr. Peterson and the work group considerations.
All right, thank you very much, and good afternoon, everybody. My goal for today's presentation is to provide some brief background as well as describe some of the considerations that our work group has taken into account in our discussions. And I hope that this provides a good introduction to the following presentation describing our proposed policy questions and evidence to recommend framework. Next slide, please. So in terms of background, orthopoxviruses are a group of large double-stranded DNA viruses within the family Poxviridae. There are a number of different species known to infect humans, including smallpox, Vaccinia, monkeypox, cowpox, and even some newly discovered species. Orthopoxvirus infection does provide cross-protection across the species, and this is what has led to the development of Vaccinia as a vaccine for smallpox and other orthopoxviruses. The orthopoxviruses remain an active subject of research, and they are used as viral vectors for expression of foreign genes, recombinant vaccines, as well as oncolytic or immunotherapies for cancer. Next slide, please. However, despite the eradication of smallpox, orthopoxviruses do continue to present a risk to public health. In particular, monkeypox has seen an increase in the number of case reports from Africa, and there have been a number of exportations, including to the United States in 2003, and more recently to the United Kingdom, Israel, and Singapore. Next slide. There are currently 2 licensed orthopoxvirus vaccines. The first is ACAM2000, which is a live Vaccinia virus vaccine that was licensed by FDA in August of 2007. And ACAM2000 replaced Dryvax, whose license was withdrawn, and the remaining vaccine doses of Dryvax were destroyed. ACAM2000 is indicated for the active immunization against smallpox disease for persons determined to be at high risk for smallpox infection. Next slide. The other licensed orthopoxvirus vaccine is JYNNEOS. JYNNEOS is a live vaccine produced from the strain modified Vaccinia ankara Bavarian Nordic and is an attenuated, non-replicating orthopoxvirus. JYNNEOS is also known as Imvamune, Imvanex, or MVA, and it was licensed by FDA in September of 2019. Jynneos is indicated for the prevention of smallpox and monkeypox disease in adults 18 years of age and older determined to be at high risk for smallpox or monkeypox infection. Next slide, please. This table describes key characteristics of these vaccines as well as important differences between the vaccines. With respect to the vaccine virus, ACAM2000 is a replication-competent Vaccinia virus, while Jynneos is a replication-deficient MVA virus that has been attenuated such that it no longer replicates in mammalian cells. With respect to administration, ACAM2000 is given via a multiple puncture technique in a single dose. Jynneos, by contrast, is administered subcutaneously in 2 doses 28 days apart. ACAM2000, when given successfully, produces a major cutaneous reaction or take, which presents as a vaccine site lesion. Jynneos, as an attenuated virus, does not produce a cutaneous reaction or take. ACAM2000 does produce a vaccine site lesion that presents a risk of inadvertent inoculation as well as an auto-inoculation. Because Jynneos does not present such a lesion, there is no known risk of inadvertent inoculation or auto-inoculation. With respect to serious adverse events, ACAM2000 does present a risk of uncontrolled viral replication, which can cause serious adverse events such as progressive vaccinia and eczema vaccinatum. No known such risks are associated with Jynneos, and this vaccine has been studied in persons known to be at high risk for such severe adverse events, like persons with HIV infection and atopic dermatitis, and no significant adverse events of this type were observed in those studies. The effectiveness of ACAM2000 was assessed by comparing the immunologic response as well as the take rates to Dryvax. Similarly, the effectiveness of Jynneos was assessed by comparing the immunologic response to ACAM2000. Next slide, please. As mentioned by Dr. Bell, the working group has discussed consolidating the current vaccine recommendations, given that multiple recommendations and guidance documents currently exist as listed here. The working group intends to update and revise these existing recommendations and guidance and present them in a single consolidated document to include all of the new recommendations and guidance. Next slide. Working to define the scope of the recommendations, the working group recognizes that current ACIP recommendations are focused only on a pre-event setting. That is, the current scenario where no smallpox or other orthopoxvirus emergency exists. Smallpox vaccine use in a post-event vaccination program is addressed in separate clinical guidance, and the working group intends to continue to focus on the pre-event setting and does not intend to focus on post-event scenarios. Next slide, please. Current ACIP recommendations address persons who are at occupational risk for orthopoxvirus exposures. Namely, these are laboratory and healthcare personnel, as well as smallpox response and healthcare teams. This is the primary population that we intend to address with our updated recommendations, as you'll see in our policy questions, focusing on persons at risk for occupational exposure to orthopoxviruses. Next slide, please. Research laboratory personnel are one of the primary populations included in this population because serious infections have occurred among this population. Vaccination with an orthopoxvirus vaccine can protect against these infections, and this is why ACIP does currently recommend vaccination with ACAM2000 for research laboratory personnel. However, the working group has also identified additional personnel, including clinical laboratory personnel, select healthcare personnel, for example, persons working with clinical trial participants, and persons administering ACAM2000 vaccine as additional populations that we feel should be addressed with the new recommendations and guidance. Next slide, please. ACIP currently recommends revaccination with ACAM2000 for persons working with replication-competent Vaccinia virus as well as recombinant viruses developed from these viruses. For these persons, revaccination is recommended at least every 10 years. In addition, for persons working with more virulent orthopoxviruses, such as smallpox and monkeypox, the recommendation is to be revaccinated every 3 years. Next slide, please. These recommendations were made decades ago and have persisted. The underlying rationale for these recommendations was initially based on epidemiologic studies demonstrating that there is an increased level of protection against smallpox, which persists for up to 5 years and after primary vaccination, and substantial but waning immunity can persist for greater than 10 years. In addition, there was data on the persistence of neutralizing antibodies following vaccination, showing that neutralizing antibody titers of greater than or equal to 1 to 10 were found among 75% of persons for 10 years after receiving the second dose. And this was the origin of the initial revaccination recommendations and revaccination schedules. This was most recently reviewed in 2015, where ACIP did see a continued need for revaccination, given that there has been some data produced since that time, but no data to significantly impact the current revaccination recommendation or schedules. Next slide, please. As such, the working group has a strong desire to try to provide revaccination recommendations for JYNNEOS. Working group recognizes that there's a greater importance for protection of persons working with more virulent orthopoxviruses, that is, smallpox and monkeypox, because of the risk for severe systemic disease at the individual level, but also at the societal level because these are contagious pathogens with epidemic potential. However, it is difficult to precisely define the duration of protection for vaccines, and the duration of protection for JYNNEOS is not known. However, as previously presented, we do know that neutralizing antibodies generally do not persist beyond 6 months following primary vaccination with JYNNEOS. However, a single booster dose of JYNNEOS given 2 years following primary vaccination with JYNNEOS does produce a robust increase in neutralizing antibodies. And this data suggests that a robust anamnestic immune response is present 2 years following primary vaccination. And this is the primary data that the working group has been focusing on in developing our proposed policy questions for revaccination. Next slide, please. Lastly, I'll just highlight that previous ACIP recommendations have included smallpox response teams as well as smallpox healthcare teams, and those recommendations are included here. Next slide, please. And the working group does recognize the benefit of having cadres of vaccinated public health and healthcare personnel available to respond and care for orthopoxvirus-infected individuals. The recent increase in monkeypox cases in Africa and importations into other countries does suggest that the risk of monkeypox exportation is increasing. However, the working group has expressed a desire to avoid being overly prescriptive in defining who and how many such persons should be vaccinated, as assessments of the threat level of these pathogens can change over time. And so the working group is working on revised language which aims to empower appropriate local, state, and federal public health and anti-terrorism authorities to make these decisions. And we hope to share that language with you in a future meeting before the vote takes place. Next slide. So I will end my presentation there, but I am happy to take any questions.
Thank you very much, Dr. Peterson. Are there any questions for Dr. Peterson at this time? Any comments? Okay, I'm not seeing any. So we'll move on to the next presentation by Dr. Rao on the updated policy questions for EtR Framework and plan for next steps. Dr. Rao, please.
Thank you. So with the background information that Dr. Peterson presented, the work group drafted policy questions that I'll present for the evidence to recommendations framework. The first policy question that the work group is proposing is listed on this slide. It is, should persons who are at occupational risk for orthopoxviruses be offered Jynneos as a vaccination option? We presented this during the October ACIP meeting. Okay, so we introduced this PICO question during the October ACIP meeting, but just to recap, the population was persons who are at risk for occupational exposure to orthopoxviruses. The intervention was vaccination with Jynneos. The comparison was vaccination with ACAM 2000, and then we identified 4 different outcomes, each of which would be evaluated on an evidence table and part of the evidence to recommendation framework. And those outcomes are prevention of disease, which includes immunogenicity, severity of disease, severe adverse events, and myo and pericarditis. So since the last ACIP meeting, the work group began discussing booster doses. ACAM 2000 is licensed for smallpox. The package insert lists revaccination recommendations for persons at risk for exposure to smallpox as every 3 years, which you can see here in the red box. You can also see more details listed below. Jynneos, on the other hand, ACIP recommended booster recommendations through extrapolation of the data for Dryvax. And Dryvax, as Dr. Peterson mentioned, is basically a precursor. It was ACAM 2000 is a live Vaccinia virus that was cloned from the same strain used in Dryvax. Jynneos is licensed for smallpox and for monkeypox, but there are actually no revaccination recommendations in the package insert. And ACIP recommendations would have to come from this group during future meetings. The work group drafted 3 policy questions since the October meeting. 2 of these are about booster doses. Persons who are at continued risk for occupational exposure to orthopoxviruses fall into 3 groups. One group is persons at risk for exposure to more virulent orthopoxviruses like smallpox or monkeypox, and the other is persons at risk for exposure to replication-competent orthopoxviruses like Vaccinia or cowpox. And finally, replication-deficient Vaccinia viruses and recombinant viruses developed from replication-deficient Vaccinia viruses. The 2005 ACIP recommendations for orthopoxviruses acknowledge the existence of persons who belong to each of these categories and provide revaccination recommendations, as you can see in the red box, for each group. And you can see that the ACIP only recommended vaccines for those at risk for virulent orthopoxviruses and replication-competent Vaccinia viruses, and that revaccination was recommended every 3 years for the former and at least every 10 years for the latter group. The first of the proposed policy questions about booster is this one. It is, should persons who are at continued risk for occupational exposure to more virulent orthopoxviruses, such as smallpox or monkeypox, receive a booster dose of Jynneos 2 years after the primary series? 2 years was chosen as the time point because we're aware of data in the systematic review that is ongoing that supports that. The population for whom this question is applicable are CDC laboratorians who work with smallpox or monkeypox, research laboratorians who work with monkeypox, and Laboratory Response Network, or LRN laboratorians at state health departments who are designated to test for smallpox. On this slide is the PICO question. The intervention is a booster with Jynneos 2 years after the primary series. The comparator is no vaccine booster after the Jynneos primary series, and the outcomes are the same 4 outcomes that were listed for the first question and are prevention of disease, severity of disease, severe adverse events, and myo and pericarditis. As you can see, the comparator for this particular policy question is different from that of the first question. The first question's comparator was ACAM 2000. The second of the policy questions about booster dose is listed here, and it is, should persons who are at continued risk for occupational exposure to replication-competent orthopoxviruses like Vaccinia or cowpox receive a booster dose of Jynneos after the primary series? And the population for this question are biomedical research laboratorians who work with Vaccinia vectors and other persons who work exclusively with replication-competent orthopoxviruses like Vaccinia or cowpox. There's intentionally no time point recommended for this booster. After much discussion, the work group felt a booster dose is likely needed for those with low-risk exposures who receive JYNNEOS. It's just that the frequency with which that booster should be given is unclear. But similar to the ACAM 2000 booster recommendations being less frequent for this population of people compared to those working with the more virulent orthopoxviruses, the work group concluded that the booster dose for this population should probably be less frequent than what is described in the PICO question I just presented. The PICO is listed here. For this, the population is persons who are at risk for occupational exposure to replication-competent orthopoxviruses like Vaccinia or cowpox. The intervention is booster with JYNNEOS. The comparison is no booster, and the outcomes are the same 4 outcomes that you've seen with the preceding 2 policy questions. And finally, the work group thought of other scenarios that we anticipate frequent questions for. There is known interest among persons who receive ACAM 2000 to switch to a JYNNEOS series for subsequent boosters. The switch from one vaccine to the other, in this case, would be an intentional choice rather than one dictated by extenuating circumstances like availability, and that is the reason that there is a policy question drafted for that. It reads, should persons who are at continued risk for occupational exposure to orthopoxviruses and received an ACAM 2000 primary vaccination receive a booster dose of JYNNEOS as an option to a booster dose of ACAM 2000? Now, the scenario for this is illustrated on this slide. If a patient who has been receiving ACAM 2000 primary series has continued to receive ACAM 2000 through booster doses at the recommended time intervals per the ACIP recommendations, and now wants to switch to JYNNEOS booster vaccine, that is the clinical scenario that we are discussing with this policy question. So the PICO question is on this slide. The intervention is booster with JYNNEOS and the comparison booster with ACAM 2000. In addition to the 4 outcomes that I've included on all of the 3 previous policy questions, we have added an outcome. We'll search for information about adverse events due to an interaction between JYNNEOS and ACAM 2000. And then similar to the previous question, this exact scenario we've depicted here, JYNNEOS primary vaccination, and then someone deciding to switch to an ACAM 2000 booster. The work group is not sure if this would be an intentional decision or not. We have not yet determined whether this would be an additional policy question because we're not sure if there is a desire for such a switch from JYNNEOS to ACAM 2000. And so we're not quite sure yet if that would be clinical guidance or a policy question. But it's thought to be a less likely occurrence than what would occur with the JYNNEOS to ACAM 2000 switch. And we just wanted to let the work group know, the committee know about the work group's thought processes to date. Now, with the drafting of the policy questions, the work group will soon be focusing their attention on the grade and the EtR for each of these policy question outcomes. And this slide is the same that Dr. Bell presented earlier today. I just want to highlight that the June 2021 meeting is when we aim to present the evidence tables, the evidence to recommend frameworks for all of these policy questions, and draft language for the recommendations that would be voted on in the future. As part of our work for the grade and EtR, we're performing a systematic review, and we're working with the CDC librarian to draft broad search terms, including the ones listed here in the first bullet. That very broad search resulted in 740 articles being identified, and you can see here in this figure from which databases each of these we obtained manuscripts that would be included. And you can see at the bottom there, total citations, 740. So during title and abstract screening, we excluded 649 records. The reasons are listed on the top right of this slide. And then after obtaining full text articles, we excluded 39 additional articles for reasons that are described on the bottom far right. And that left us with 45 papers that we're in the process of abstracting. So just to give a sense for the challenges that we're experiencing right now with the abstractions, the Jynneos is unlike ACAM 2000 in that there's no vaccine take and there's no standardized definition of seroconversion. So each of the papers that we're reading uses a different criteria, and that's posing some difficulty for us in trying to abstract that information, but we are working on that. Data about long-term immunogenicity and need for Jynneos booster is limited because it's a new vaccine. People who are defined as Vaccinia experienced subjects in clinical trials may have had variable exposures to Vaccinia. For example, they may have had previous vaccination with Dryvax or ACAM 2000 or Vaccinia infection. And then deduplication of data is something that is always a challenge. It's clinical trial data may be reported in multiple records, and so we're working to sort that out. So we are aiming to do we're doing a very thorough job at this. We are keeping in mind for the ETRs and clinical guidance discussions that there are differences between these two products. Now this slide is borrowed from the presentation Dr. Peterson just gave. It's just a reminder of all the differences between the products and a reminder that we are taking all of these into consideration in all of our discussions. Some of the considerations for the evidence to recommend framework are those listed on this slide. We know that access to providers with the training to administer ACAM 2000 is sometimes limited. People have told us that they often have to travel to a different state and pay for their own travel expenses just to see a provider who's trained to administer it in the specialized way with a bifurcated needle. There's no visual evidence for immunogenicity, for example, via a take, and some might find that disconcerting, and if they're working with smallpox, want proof of an effective vaccination. There are 2 clinic appointments needed for Jynneos vaccine, but only 1 for ACAM 2000. And the cost is something that we have talked about, but would not really figure into our discussions because both vaccines would be available from the U.S. Strategic National Stockpile, free of cost to the vaccine recipient. This is just a taste of the work that is to come during the next ACIP meeting, and I guess we can now open it up to questions.
Thank you very much, Dr. Rao. Open for discussion. Anybody from the voting member group? Oh, Dr. Messonnier?
Yeah, I have a question. The way that I read this, if I'm reading it right, the question is a booster, which would then imply that you'd have to come back in 2 years for a second booster, or is it going to be such that it'll allow multiple boosters?
Yeah, no, I think that's a good question, and let me see how it's phrased here. It should be a booster at least, so for the first booster population, it would be every 2 years, and for the second, it would be at least every, let me see, let me pull it up. You can just say that, yes. Okay. So here's the other one. Should persons who are at continued risk for occupational exposure to replication-competent orthopoxviruses like that receive a booster? So you're right. I guess you're asking, should it be? It really should be. Should receive boosters after the Jynneos primary series.
Right, because otherwise you're going to be back here in 2 years asking for a second booster.
Yes, point taken. Well, we will correct that.
Thank you. Dr. Fry, please.
Thank you. Nice presentation. So I was just wondering what the MVA 2-year data looks like compared to ACAM data at 2 years as far as neutralizing antibody results, GMTs or whatever. I mean, are they similar? I know they both products cause a CMI response, which was similar at the short term, and both had good antibody responses as well as compared to dry vax also. I was just wondering if there's any comparison of the MVA antibody response to the ACAM response at 2 years out or 3 years out. And why, if they're similar, why would we treat the two products differently? If that makes sense.
Yeah, thanks, Dr. Fry. So the data that we did present, actually the manufacturer of the vaccine presented at the last meeting, did indicate that persons who received a primary vaccination with Jynneos and received a single booster of Jynneos 2 years following did show a robust anamnestic response. This wasn't compared directly with a response to ACAM 2000, but the titer levels, I believe, would be considered similar. There are difficulties, obviously, as we've shown, comparing the two vaccines because they are, in fact, different. So the working group really wants to go based on the data available and does not feel that it's really reasonable to try to equate the two vaccines because they are, in fact, different biologically. So I hope that helps answer your question.
Thank you, Dr. Peterson. Dr. Lee.
I just have a really quick comment. First, I wanted to, thank Drs. Bell, Peterson, and Rao for two things. One is for taking all of the prior recommendations and trying to harmonize them into a set of recommendations that are in a single form, because I think that'll be extremely helpful. And then the commenter's question I may perhaps have it is not specific to this group, but I've just been thinking and reflecting on the last 2 days. Has it been 2 days? Yes, it's been 2 days. And thinking that it would be really helpful, I think, as we continue to have a greater number of recommendations that relate to occupational exposure and healthcare workers, plus or minus immunocompromised folks, to think about how to make that simpler to use and implement for those who are on the front line. I have to say I still go to the ACIP colorful tables all the time when I'm having to remind myself about catch-up vaccines. I feel like the breadth and the depth of the recommendations are just growing so quickly that it would be great to think about how to make it more user-friendly. Thank you.
Thank you for those comments. Yes, we will do so. Any other comments or questions? I am not seeing any. I will see if our Executive Secretary, Dr. Cohn, has any comments towards the end here.
I know everybody's wanting to stay until 5 o'clock, and I'm so sorry we're ending early, but hopefully we won't have to tack on that extra half an hour or hour and a half on Sunday or Monday. So we are looking forward to seeing you again at 11 a.m. Sunday. And the draft agenda is now on the website. The web link, I think, becomes available about 24 hours in advance of the meeting. And we anticipate if there's an FDA EUA for the new COVID vaccine, the Janssen product, we anticipate voting on a recommendation related to that vaccine on Sunday, and then having additional discussion on Monday about vaccine safety surveillance and considerations and for clinical and implementation issues. So we look forward to that. And I'll turn it back over to our chair to close the meeting.
So again, thank you all for giving of your time. Today's our two-day session was intense, and there was a lot of robust and good discussion. Again, we'll see each other in 2 days for another two-day session. We really appreciate the amount of time you're dedicating to this. And I hope that you get some downtime in the next 48 hours. So enjoy your time off. We'll see each other in 2 days, and I gavel us to a close.